tengo el placer de presentar al chair de este segmento, que es el profesor Hans-Peter Hartwig. Él es profesor de neurología de la Universidad Heinrich Heine en Düsseldorf, Alemania. Es profesor honorario de cerebro y del Centro de Cerebro y Mente. Es parte de la Facultad Médica de la Universidad de Sydney en Australia y, por supuesto, recientemente copresidente de la Fundación Charcot Europea. El doctor ha sido prácticamente todo: presidente de MEXCTRIMS, jefe de neurología, dueño de la cátedra de neurología, y a lo largo de su vida pues ha hecho muchos estudios en la investigación clínica y translacional, también en el campo de la neuroinmunología básica y clínica, en la exploración de los mecanismos etiopatológicos de las enfermedades autoinmunes, ha definido el rol de los retrovirus humanos, ha diseñado él mismo nuevas intervenciones y ha promovido tratamientos para la reparación in vitro en modelos experimentales y en ensayos clínicos. Por supuesto que cualquier artículo que ustedes lean sobre esclerosis múltiple viene citados los miembros que hoy vamos a escuchar en este simposio, todos ellos. Y pues no les puedo detallar toda su actividad, pero el doctor tiene más de 1,000 artículos, más de 1,200 artículos en revistas de prestigio indizadas, más de 100 capítulos de libro, y tiene muchos ensayos como investigador principal de fase 2 y de fase 3. Pero muchísimo más allá de eso, el profesor Hans-Peter, Peter para los cuates, es amigo de nuestro país. Siempre viene con mucho gusto y pues no está muy fácil porque no existe ninguna clase de vuelo desde Düsseldorf. Con él van a estar Georgina Arrambide, quien ha hecho un gran esfuerzo también al venir desde Barcelona, desde donde no hay vuelos directos tampoco, Daniel Ontaneda, que viene desde Cleveland, y la doctora Letizia Leocani, que pues está en Milán y desde ahí va a platicar con nosotros. Hans-Peter, please.
Muchas gracias, Gloria. Just before I start, well, thank you very much for the somewhat extended, very kind introduction. Before I start, I would just like to re-emphasize how glad the European Charcot Foundation is that we can continue our collaboration and that you invited us to be part of your great meeting. So the meeting, the Charcot satellite, if you like, or foundation symposium is dedicated to an overview of the developments following the deliberations of the International Panel on the McDonald diagnostic criteria that are hopefully soon be published. You've heard about them, I guess, many times, so I apologize up front that you may get bored by my presentation, but repetition leads to reinforcement of concepts, and that may not hurt too much. So this is a picture you probably have seen quite some time, showing the group of some 50 plus colleagues who were convened in Barcelona in December 2023, and there was a follow-up meeting at MEXCTRIMS in Copenhagen. And 3 people that took part are here. two important people, Georgina Arambide and Daniel Ontaneda. This is just to recap the composition of the international experts, also reflecting more than in the past the global problem and expertise in multiple sclerosis, and importantly, we did a better job in getting the gender balance right. Well, you are all aware of the general principles that hold to establish the diagnosis of multiple sclerosis, which, as you know, occurs throughout the world in all geographic regions, races, ethnicities. There's been a secular trend of a rising incidence and or prevalence. The fundamental prerequisite for the diagnosis has remained the same, and this is MS is an exclusion diagnosis. Brain and spinal MRI continue to be the most useful paraclinical test to aid in the diagnosis of MS. A normal MRI showing typical lesions is required to make the diagnosis, and it's important to realize that misdiagnosis as well as underdiagnosis may have deleterious consequences for patients. Statements applied to a clinically isolated syndrome may also be applied to patients with a previous history of relapses without a diagnosis yet. And this is from Alex Sorvira, just showing very nicely how we consider brain and spinal cord to be absolutely essential in making the diagnosis and ruling out alternative diseases. Well, the diagnosis or the entity was most clearly described, as you know, by Charcot in 1868, but it was then in the 1960s that Shoemaker started his work with a number of eminent colleagues because they wanted to be better in making the diagnosis for patients to be enrolled in clinical trials. So this is the classical triad described by Charcot. You see here the criteria laid down by the Shoemaker committee, and as we go on, there is obviously more knowledge and incorporation of paraclinical tools to help in the diagnosis. The McDonald criteria and their renditions, first published in 2001, made use of the then emerging evidence from MR imaging and also other paraclinical tools. And as time went on, new evidence was added and integrated into the diagnostic criteria, and there was a continuous attempt to make the diagnostic process more user-friendly, if you like, more reliable, more reproducible. And you see here the further incorporation of knowledge and criteria provided as regards MR by Magnims, and the latest rendition I will briefly introduce to you, and then we have the experts to further dive into them. Well, obviously, diagnostic criteria have significant impact on various aspects in terms of the prognosis, in terms of clinical trials. As I mentioned, this was the driving force behind the Shoemaker et al. Criteria. They influence the decisions which kind of treatment, and fortunately we have many, should be chosen in a given patient, and they are important for the patient-physician dialogue. Why are new diagnostic criteria necessary? We do have an improved understanding of the underlying disease mechanisms. There is or was a need to enhance the sensitivity and specificity to recognize disease early and with fidelity, incorporate novel diagnostic tools, standardize across various clinical settings, facilitates research and drug development, and adapt to the varied global health needs. This is just a paper published a couple of years ago that have demonstrated in a comparative analysis of applying 2010 and 2017 McDonald criteria to cohorts in terms of sensitivity and specificity, and what you can easily appreciate. Whatever study you look at, there is a lessened specificity, but increased sensitivity with a later version of the criteria. So this is the list of the revisions that were discussed and then agreed upon. One important aspect, not unlike other neurological disorders, think of Alzheimer's or Parkinson's. We think of MS, of course, as a biological disease, and this should be reflected in the diagnostic process. RIS is MS in specific situations, the important inclusion of the optic nerve as a fifth topography, and I remember we were almost there in the 2017 criteria. We had long discussions at the time in Berlin. Now the evidence has become even more robust to justify the inclusion. Very importantly, dissemination in time is no longer needed. So the diagnosis can be made earlier. There are updated criteria for dissemination in space, and we added another paraclinical tool to the CSF findings of restricted oligoclonal bands, and this is the kappa-free light chains. Importantly, the same criteria hold for both progressive and relapsing multiple sclerosis. There are recognizing the potential confounding factors, more strict features required to confirm the disease in individuals above 50 or with headache disorders or with vascular disorders. And importantly, and this will be discussed in greater detail by Professor Ontaneda, the central vein sign and paramagnetic rim lesions have been added as optional tools to establish the diagnosis in certain situations, providing also more specificity. And as you will hear from Georgina Arambide later on, laboratory tests have been incorporated, and I foresee that more will come. You all know this concept of radiologically isolated syndrome by first described by Okuda and Lebrun, the incidental discovery of white matter lesions on MRI that demonstrate morphological and spatial features of highly typical MS, but occur in the absence of clinical symptomatology, are fortuitously or incidentally discovered when working up other conditions. And the majority of patients will have MS, of those with RIS, within a matter of 10 years. You see here a compilation of this conversion extracted from a number of papers from the RIS International Consortium. So the recommendations of the panel are that in patients with RIS, fulfilling of dissemination in space and time is sufficient for the diagnosis. Likewise, fulfilling dissemination in space and the presence of OCB and CSS are sufficient for diagnosing MS. And thirdly, the presence of at least 6 central vein sign containing lesions when dissemination in space is fulfilled suffice to diagnose multiple sclerosis. So it was a strong motivation to, like in previous rendition, make the diagnostic process utilizing the criteria operationally more easy and widely applicable. And these are the 5 areas where we thought this could be achieved: the optic nerve as 5th topography, the no longer existing requirement for dissemination in time, and the others that are highlighted here. Now this is a summary of, a very nice summary from the Barcelona group, published last year, looking at optic neuritis and the relation to multiple sclerosis. As you all are aware, there's a high likelihood of optic neuritis patients to convert to multiple sclerosis. The frequencies depend on the methodology used, and the involvement obviously can be ascertained by MRI, visually evoked potentials, and OCT, and the latter will be discussed by the next speaker, Professor Letizia Leucani. So, in terms of the assessment of the visual system, it was detailed that there should be certain features on MRI after excluding other ophthalmological or systemic conditions that could explain optic neuritis. In terms of the neurophysiology, visually evoked potentials, obviously the asymmetry or P100 latency delay may serve as evidence of optic nerve involvement. And finally, the knowledge accumulated over the past decade or so on optical coherence tomography, which was discussed earlier today by our president, may serve as evidence to show that the optic nerve is involved, and therefore helps to establish dissemination in space. Now, again, one of the many fantastic contributions from the Barcelona team. Here is an analysis of all the CIS clinical trials. You see them on the left-hand side, the characteristics, and the survival estimates for dissemination in time basically show very or almost identical curves, and clearly demonstrate that the waiting for an additional attack or evidence of disease activity dissemination in time apparently is not needed any longer. Here, about the sort of revisit of the criteria of the CNS topographies that need to be involved in order for dissemination in space to be ascertained. The fulfillment of DIS plus OCB or the kappa-free light chain is sufficient to diagnose MS. And in patients with typical symptoms, the presence of typical lesions in at least 4 topographies is sufficient. In patients with typical symptoms and typical lesions in 1 topography, the presence of 6 central vein signs or paramagnetic rim lesions plus dissemination in time or positivity of CSF findings suffices to establish the diagnosis. And with regard to progressive disease, the detection of 2 spinal cord lesions are enough to demonstrate dissemination in space. So let's turn to kappa-free light chains as an appropriate paraclinical tool for diagnosis. An excess of kappa and lambda-free light chains can be produced during chronic intrathecal inflammation. The advantage and nicety of determining this is this measure is rapidly, reliably, and quantitatively detectable, and several studies have clearly indicated that KFLC have diagnostic properties similar to those of oligoclonal bands and multiple sclerosis. And this paper shows you the similar degree of sensitivity and specificity of detecting the kappa-free light chains and the oligoclonal bands. KFL differentiates CIS and MS from other neurological diseases. I mentioned the diagnostic property similarities, and hence KFLC could represent a valid, easier, more reproducible, and rater-independent alternative to compared to oligoclonal bands. So kappa-free light chains are interchangeable with oligoclonal bands and consequently can substitute for excuse me, OCBs in the diagnostic process. Now, as I mentioned earlier, we've realized over the years that the 2017 criteria, while providing more sensitivity, lacked in specificity, or had a lower specificity, and therefore there was and is a need to increase the specificity, and this is tried by the 4 points highlighted. The need of further paraclinical evidence, more strict features to be applied in certain age group, both in the aged patients with risk factors and also in the pediatric population, and the addition of some newer MR features that are characteristic and can be viewed as optional tools for the diagnosis in certain situations. And it was also deliberated on the utility of more IgG antibody testing in children and adolescents. I will not go into detail. This will be done by Professor Ontaneda, the central vein sign reflecting the long-known pathological feature of perivenular inflammation occurring across lesions. The NIMS criteria for your reference are listed here, and on the lower left you can see that CVS detection helps to clearly differentiate MS from other conditions and mimics given its higher frequency. And then in terms of the particular degree of sensitivity and specificity, several categories were examined, and the number read out in terms of the number of CVS and the rule of 6. So presence of 6 central vein signs was considered to provide the highest degree of sensitivity and specificity. So demonstration of CVS can increase the specificity of the diagnosis. It is, however, not required to make the diagnosis. In patients with typical symptoms and DIS, the presence of the rule of 6 CVS lesions suffices for the diagnosis. And in patients with typical symptoms and typical lesions in one topography, the presence of 6 CVS plus dissemination in time or CSF positivity is sufficient. Paramagnetic rim lesions, again, drawing and capitalizing on the evidence that has accumulated over the years, will be considered a legitimate paraclinical tool. You know, these rims made up basically of active microglia that by virtue of generating and releasing toxic oxygen species cause damage. They also have prognostic value over the time. You see here on the right-hand side a couple of those nicely depicted lesions from the Stevenson review. And again, you will hear this in more detail, the presence of PRLs in the group or across the spectrum of MS shows higher incidence and compared to other CNS disorders, and the Magnum's group has provided clear evidence underlining this, and this, I guess, will be discussed later on. So I don't want to repeat myself, just to again emphasize that PRLs may serve to increase the specificity of the diagnosis. And then the group came up with algorithms reflecting the advances in the diagnostic criteria. So if you encounter patients with signs or symptoms suggestive of MS, there's an initial workup, particularly to exclude mimics. And then you have a dichotomy depending on the presence of involvement of CNS, or the number of involvement of the CNS topographies. They're listed there, and the advancement recently is shown on the lower right panel, where you can diagnose MS with additional features that I just described briefly. And this is particularly highlighted for the patients that have either lesions only in one CNS topography, or where you have CVS and lesions in more topographies. Again, there is an algorithm that you should follow in order to establish in these particular contexts the diagnosis of MS. And the panel also concluded, and this will be shown, that radiologically isolated syndrome for a large part can be considered multiple sclerosis if particular diagnostic criteria are fulfilled. Special considerations that I already referred to are patients at a higher age. It's all relative. I can painfully confess in front of you what you consider higher age. So we are talking about age above 50 and patients that have the confounding overlying comorbidities that superimpose potentially pathology on the underlying MS-driven pathobiological disease process. So in these particular situations, additional features should be fulfilled to confirm the diagnosis, and these are a spinal cord lesion, positive CSF, be it through demonstrating OCBs or KFLCs, and the CVS as an additional feature. The other group specifically looked at patients in childhood, adolescents below 18 years. Here again, CVS is an important feature to discriminate and suggest MS, and the MORG IgG testing using a cell-based assay is strongly recommended in children with an incident demyelination under the age of 12 years. And again, in patients at 12 or above an incident demyelinating event, MORG IgG testing using this cell-based assay is advocated in the context of an atypical presentation. Primary progressive MS, I mentioned that we established a unified framework of the diagnostic criteria, the classical requirement for clinical progression over at least 12 months, and then the uniform application of diagnostic criteria outlined before for relapsing MS patients. And, as I mentioned, the presence of at least 2 spinal cord lesions is evidence enough for dissemination in space to make the diagnosis of PPMS. So taken together, the revisions discussed and outlined here, I think, reflect our advanced knowledge in MS, enhance applicability, make it more user-friendly and doable in various clinical contexts, importantly increase the specificity and may speed up the diagnosis, and with all this in aggregate have a significant, I think, positive impact on the treatment of our patients. So what would be the open questions for a further future revision? The demonstration of dissemination in time using optical pathway alterations monitored by VEP and or OCT, the refinement of the use of PILs and CVS, then specific atypical presentations like solitary sclerosis, then to more in greater depth reflect the potential different presentations across the globe and how that affects the performance of the criteria, and the greater reliance of biological markers of the disease, irrespective of clinical presentations or absence thereof, and finally the use of other biomarkers as paraclinical tools for diagnosis. In summary then, the new version of the diagnostic criteria have been formulated to balance the need for earlier diagnosis with the imperative to minimize diagnostic errors. Recognize the optic nerve as the fifth topography in dissemination in space. Utilize central vein sign paramagnetic rim lesions in special circumstances to enhance diagnostic specificity. Consider kappa-free light chain index as a simpler and more cost-effective alternative to OCB detection, using the same diagnostic criteria for PPMS and RMS, and stipulate the use of additional diagnostic methods in patients with a higher risk of diagnostic error. And with this, I'd like to thank you very much for your attention. It's my pleasure to now introduce, by remote contribution, a talk by Professor Letizia Leocani on the role of assessing the visual system in making the diagnosis. Professor Leocani is a neurologist and neurophysiologist, a professor at Università Vita Salute in Milan. She is one of the world's leading experts in studying the visual pathways, VPs, OCTs, and also a leading expert in using digital tools to monitor multiple sclerosis. She's the chair of the EMA Committee for Neurological Devices and has a long track record of contributions to the field. So it's a pleasure to have her here, albeit remotely.